Lin, welcome to the Talking Gut podcast.
Thank you for having me.
I'm so thrilled to have you on board today as part of this topic, which is stress and gut. And I guess that includes disorders of gut-brain interactions. And it's, again, a really wonderful pleasure to see you again. This is a really interesting topic, but before we get into it, in all the interviews that I've done, I've always wanted to sort of get an insight in terms of, and I'm always interested, how did you get to be here?
It's not a short story and it's not a straight line.
We have all the time. We've got time.
Well, really, honestly, it starts with my family.
Okay.
Where, I'm Chinese and my father's from Hong Kong and my mother's from mainland China.
Yep.
And they met in Los Angeles.
Yeah.
And got married. And as all Chinese families do, they want a son, but they got 4 girls, one right after the other. And I'm the third of 4 girls. And my father then, when he couldn't have a son, he also wanted someone to be a doctor.
Mm-hmm.
I didn't know what it meant to be a doctor. I had no doctors in my family.
Mm-hmm.
But my mother got sick when I was a teenager, when I was 13. She ended up having metastatic kidney cancer.
Oh.
So she passed away, but it was interesting. I taking care of her, like I actually gave her morphine shots back in that day. That was a long time ago that they did that at home. But she told me, you don't have to be a doctor if you don't want to be. And it's interesting as a child, when your parent finally tells you don't have to do something, then all of a sudden you think, oh, maybe I should do it. And the fortunate part about medicine is that there's so many different specialties. Mm-hmm. So you can really pick one that suits your personality, your interests. Mm-hmm. So I thought I was going to go into surgery, as many gastroenterologists think, and I ended up going into internal medicine. But I knew I wanted to specialize, and I was thinking of different specialties, but I decided to do GI. And I did GI, and I did a little bit of motility research with Bill Snape. But I was actually going to go into private practice. But my husband wanted to do vascular surgery. So after fellowship, we moved to Los Angeles to Mayo Clinic, Rochester, Minnesota, where he did vascular surgery. And Mayo Clinic, that year at Mayo Clinic was a pivotal year for me. I was very impressed there. And I decided then that I was going to go into academia. We came back to Los Angeles, and we both worked at the county hospital that's affiliated with UCLA. And I was doing GI bleeds, general GI, gallstone pancreatitis study. But I knew that wasn't really what I wanted to specialize in. And so I had an opportunity from Emmer Meyer, who was at that same hospital, but went to UCLA, the main UCLA, and was looking for someone to help him recruit for IBS, for irritable bowel syndrome studies. So they said, oh, you should work with him. So I started doing that, and I got very interested in it. And then after 4 years at this county hospital, I actually moved to UCLA, now switching completely from a clinical job to research. And then I started spending so much time understanding functional neuroanatomy and brain gut axis. And it was a steep learning curve. And then I just devoted myself to, functional GI, which now we call, brain gut disorders, and did a lot of research. And my career has really evolved over the years. It really started as patient care, then research, then, more society work and committee work, and now I'm the training fellowship training program director, and now I'm the vice chief, so that became more administrative. So I feel like my career has hit on all aspects of medicine, which has been nice. So it's just an evolution.
So today's topic is stress, distress, and the gut. And I guess the gut, we talk about functional GI disorders or disorders of gut-brain interactions. Perhaps we should just start off by, what is stress?
A challenge that you have to be exposed to, and then you have to meet that challenge. And I think there's good and bad stress, and stress often makes us more efficient. You step up to the plate, and there's physiologic changes that occur for us to mount a good response to stress.
Yeah.
And they call that allostasis, or Bruce McEwen coined that. So you have this physiologic change and you go back to an equilibrium state. But then when I see patients, it's usually trying to find the story of the allostatic load moment, of when do they reach that threshold where now they have a dysregulation in their stress response systems that now lead to disease or to symptoms that they can't quite get back to a good homeostasis or equilibrium state that they had prior to that. And it usually is that patients have gone through something for some time, because in general, humans are very resilient and they're not going to break down, by the drop of the hat. It may seem like that, you feel like you didn't do much and all of a sudden you fracture your ankle, but it's really because there was some weakness there and it didn't take that much to actually tip it over. So that's usually, I'm usually looking for something like that. So I tend to look at stories for where stress is related to their symptoms or to their flares over time. So it's really good to step back and look at the timeline. But in general, I think of stress as, what was it as a risk factor, that there was stressors that increase someone's vulnerability to getting disease or symptoms. And it's not just IBS or disorders of gut-brain interaction, right? It's heart disease or lung disease, cancer, diabetes, obesity, drug abuse. So there's stressors that increase your risk. And there's also, once you get the condition, stress can trigger an exacerbation. So those two aspects in a history is what I'm looking for.
Yeah, I think the question is, how does stress affect the gut?
In so many different ways.
Yeah.
So, and this is based on animal studies and human studies, but stress can affect the immune system, motility, secretion, sensation, the autonomic innervation. So there's so many different ways that that stress can affect directly the gut, but also through brain-gut pathways. So if you're going to think about just the gut, you have to think about, it could either slow or speed up motility, and that could be through neural pathways or neuroendocrine pathways. And then, stress can also increase the permeability of the gut. It also has more of a pro-inflammatory effect. It alters a motility, like I said, and then it also affects the brain, which affects the gut. So it can affect certain networks in the brain that can enhance arousal, which makes patients more perceptive of what's going on in their bodies or even in the environment. And it affects the autonomic nervous system, and it affects the pain pathways. So if you're ever in a hyperarousal state, in a hypervigilant state, it's harder to engage the pain inhibitory pathways. And if you can't engage pain inhibitory pathways, then you are more likely to have chronic pain or recurrent pain. So there's pain pathways, there's autonomic system, so there's so many bodily systems that affect and eventually gets to gut symptoms. So it's really very complex.
So it really isn't, it's not possible to sort of say that the endocrine versus the nervous system is more dominant, in that it's all an interaction, I guess, a systemic interaction.
Yeah. I kind of think about it like this. The only way we're resilient is because we have so many different systems and pathways in place. And if one gets affected or perturbed, there's a counter-regulatory pathway to make us function. If there's only one pathway and it gets dysregulated or it gets injured in some way, we would break down, right? But there's a reason why we're resilient. But that means that a lot of different systems and cells and communication occurs. It's like, to me, an orchestra. If just because one violin player could make it to the to the performance, the whole system isn't going to break down, but you're going to feel the effects of it, and there's going to have to be some compensation. But I read a paper some years ago that looked at the different factors related to stress that had a physical or physiologic impact on the body. And I tell my patients this because I see this. So the two aspects of stress that have a physiologic impact on the body are when they're negatively perceived by others, or they're out of their control.
And it's interesting because the loss of the control, as you mentioned earlier, it is one of those, it is what we find with the majority of our patients or clients is it's one of those maintaining factors, because the need for control certainty results in hypervigilance and checking. So there's that sort of feedback loop that occurs.
Yeah.
And they're just
I would
stuck.
say that, to me, it seems like one of the hardest aspects of having these conditions is the unpredictability.
Mm-hmm.
And that makes you very hypervigilant,
Yeah.
or have symptom-related anxiety.
Yeah.
Which I tell my patients is just protective,
Yeah.
right? It would be weird not to anticipate something that could negatively happen. But a lot of times that unpredictability is what, and the lack of control is what is challenging. And a lot of what you do and behavioral techniques is really to have the patient learn some skills
Yeah.
to have a greater sense of control over their symptoms.
Yeah, different ways of experiencing it and working through it. Where, in terms of the research that you've done, and you've talked about and written about adverse childhood experiences and genetic predispositions, and I guess this sort of goes into the biopsychosocial model of IBS, or disorders of gut-brain interactions. Could we talk a bit about that in terms of what the research says around that?
Mm-hmm. Others have studied adverse childhood experience, particularly with abuse, emotional, physical, and sexual abuse, and how that increases the risk of getting IBS or other functional GI disorders. I was also wanted to look at other adverse life experiences, not just abuse, because there's other adverse life experiences, like having mental illness in a parent or in the household, and other more general traumatic or difficult childhood experiences, and how that increased the risk, because there are now different ways of measuring that. And the one in the United States that is used, a questionnaire that's used in large scale studies, I mean, thousands and thousands of patients, is the ACE, which is the Adverse Childhood Experiences questionnaire. And so I used that in addition to other questionnaires, and studied and found that if you had an ACE, or an adverse childhood experience, it increased your risk of getting IBS twofold, just like other chronic illnesses. And that the more you have, it's a greater relationship, the more increased risk that you have for getting these chronic illnesses, including IBS, and that it increases your symptom severity and also decreases quality of life. I was also looking for something protective. And the one questionnaire that I had that we found is protective, because everything always seems to be, a risk, is confiding in others about the traumatic event around that time. So that was one thing that was very interesting to me, because we're always trying to figure out, how can I prevent this from happening? How can I prevent this individual to not get to the stage where they're coming into your office or my office? And the intervention would be some of these behavioral techniques, but it's also support and confiding, and be able to get some counseling or sharing that. There's a lot of children probably never shared it with anybody, or didn't want to tell anybody, or were told not to tell anybody. And so you could see that when a child is growing up, when they're supposed to have maturation of all their adaptive systems, that if it doesn't allow it to mature appropriately, then they're going to be more at risk for the wear and tear and the breakdown of those systems.
I wonder, and it hasn't been, to my knowledge anyway, much research in this area, and that when you were just mentioning that and talking about this, I was thinking shame. I wonder whether that confiding in others is tied into not feeling that, or managing that shame.
Yeah, I mean, can you imagine being young and not really even understanding what's happening, where you are? I mean, you have no control over that situation. And yeah, I definitely think so. And IBS patients, even without that, feel shamed because because it's a gastrointestinal condition that's not really easily shared, and definitely about an adverse event. It feels like a weakness.
It's a taboo topic, and it's anything that's obviously excreted through the body is perceived as disgusting. My son and I, he's 11. We talk poop and and joke around it.
Well, I have two sons, and they said that I always bring up bowel movements or bowel habits at the dinner table, and I really don't think I do. But maybe I do, and I don't realize it.
I like to tease my friends when they come out, mainly my wife. Sort of after they come out of the bathroom, I'm like, "So how'd you go?" and they're like a deer in headlights. I think they've gotten used to me by now. In terms of, I mean, again, going back to the biopsychosocial model, I guess, of DGIBs or disorders of gut-brain interactions. But I use that analogy as we're born with a certain set of kindling, like for building a fire. And the early adverse childhood experiences is like we put more kindling on, and whether it's antibiotic use, we're building up this kindling. And one day something lights this fire, and again, this might suit the post-infectious IBD model. And there's a big roaring fire, and instead of it sort of settling down in terms of a normal fire, or someone who doesn't have this buildup of kindling or this vulnerability, the anxiety plays a role of throwing logs in the fire and keeping the fire burning.
Yeah, I can see that. The way I think about, nature and nurture and the genetic and the environmental is that there are twin studies and also GWAS studies that have shown that there is genetics do play a role in IBS and these other conditions, but it's responsible for a small variance of the phenotype of the presentation. So to me, it seems like it's more, not so much the genes that we're born with, really the gene expression. So, like you can have twins, identical twins with 100% shared genes, but they could be very different. And that's probably because there's a different gene expression of those genes. And the environment can alter gene expression. And one of the ways that it does that, and they've shown this in animal models, is through epigenetic changes. So you can have modifications on the genes that will alter gene expression. It can silence it or it can activate it, increase it. Experiencing those environmental adversities can cause epigenetic changes. And one of the ones I've been looking at is DNA methylation. So DNA methylation is one of the epigenetic changes that can occur that have been linked to early life stress. And it means that you have a methyl group that's is attached to a certain part of the gene. It's between a cytosine and a guanine, and they're called CPG sites. And if you have methylation in certain parts of the gene, particularly in the promoter region of the gene, then it could silence the gene. So that's been linked in early life stress animal models to having a hyper-responsive cortisol response, which they found. And the reason why is that when we are under stress and we secrete CRF, ACTH, cortisol, we have a negative feedback system in our bodies to control the amount of cortisol. We don't want to be on steroids all the time. And one of those receptors that helps for the negative feedback that cortisol acts on to suppress the whole cortisol response, that gene gets methylated in early life stress models. And when that receptor gets suppressed, then you don't have enough negative feedback to suppress the cortisol response. Then it gets this hypercortisol, like this, exaggerated stress response. And that's been linked to epigenetic changes. So that's one of the areas that I've been doing in research, studying that in immune cells in the blood and also in the bowel, in the colon. And I'm working on actually a blood test for IBS that's based on DNA methylation changes. And it all came from studying stress, studying early life adversity, looking at animal models, and then seeing how you can adapt that to IBS and to the human condition.
Sounds like a space to watch, and it's really interesting. It's great. You've also published about this and talked about this in terms of a GI-specific anxiety on gut compared to generalized anxiety.
Yeah.
Are they different?
Yeah, I'm really glad that we had studied this GI symptom-related anxiety because I think it's so clinically relevant.
Yeah.
I think when a healthcare provider or physician sees a patient, they'll say, oh, they're anxious. Well, they may have a good reason to be anxious that's related to their symptoms. It's not that they have general anxiety and fear of snakes or airplanes. It was really, or going outside their house. It's really symptom-related anxiety. Again, I think it's more protective for them. But so I think to differentiate, that's really important. And I always thought that, if you can reduce their symptom burden, their symptom severity, that their GI symptom related anxiety will get better. It may take a while to get better, but they're not going to be looking for, every bathroom in every corner anymore if their symptoms are under control. I do think that people who do have anxiety, though, their symptom related anxiety is going to be higher.
Mm-hmm.
And even if their GI symptom burden isn't as high, and it's probably harder to resolve that if they have general anxiety. But anxiety is more common in these disorders just because of the unpredictability of the symptoms. It really makes sense.
It's interesting that you and you're absolutely correct in terms of the GI specific anxiety. And unfortunately, if there are not disease specific measures, it's not really picked up, and because they don't have generalized anxiety. And a lot of the measures that psychologists, I guess, use is for generalized anxiety, and they don't rate so high on that. But in terms of disease specific, when you go through that individually and you ask those questions, they're very anxious. So
well, that's why we developed that questionnaire.
Yeah.
The visceral sensitivity index to really measure, GI symptom specific anxiety, but it was really meant for IBS.
Yeah.
But we're doing a study where we're trying to adapt it to IBD, inflammatory bowel disease.
And even though this wasn't in the questions that we sort of had planned for today, but I guess if we're looking at, we know we've talked about in terms of with IBS or functional disorders, with IBD, do we know how stress? I mean, we know stress in terms of, you talking about inflammatory processes that occur. Is there anything else outside of that that can contribute to the outcome or the disease expression?
Doug showed me some studies done many years ago that showed that having stress would predict having more symptoms. I think it was like 3 months later or in 6 months. And Charles Bernstein in Canada has also done some of those studies. So we do know that stress increases symptom severity, and there's some studies that are being done at UCLA right now. But definitely,
this is in IBD.
In IBD, in IBD, in ulcerative colitis. Looking for, if someone's in remission, what predicts them to have a flare. But we did a study some years ago where we looked at GI symptom severity, psychological symptom severity, and quality of life. And both psychological symptoms and GI symptoms severity impact a more negative quality of life in both conditions, whether you have IBS or in patients with inflammatory bowel disease. But what was interesting is that the correlation between GI symptom severity and psychological symptom severity was higher in the inflammatory bowel disease patients than in the IBS patients. So the IBS patients didn't have as tight a correlation of having some mood alterations and having high symptoms, but the IBD patients did. So when their symptoms were more severe in their gut, they had more psychological symptoms, and that affected their quality of life.
Yep. In saying this, and we're talking about stress as a precipitating factor, I guess, and we know that psychological treatments and interventions help. What about psychotropic medications for managing stress or anxiety? How do you interact and evolve these psychotropic medications?
Yeah, I use them quite a bit. I really try to institute a multidisciplinary care approach, and we're lucky that we have an integrative GI program at UCLA. So psychotropics or central neuromodulators are useful. I don't use that in everybody. It depends on what the patient also is interested in. The physician and the patient have to agree on what they feel they're interested in using, and at that time. And so you can choose them based on what the patient's presenting with. If someone has depression and they have abdominal pain, duloxetine, an SNRI like that would be useful. But you can also use a tricyclic agent and behavioral therapy. So the tricyclic is really trying to help the GI symptoms, and if you're trying to affect mood or the coping behavior, then you could do behavioral approach to be combined as well. I ask a lot about sleep, because sleep can also affect GI symptoms. They can worsen the GI symptoms. So sleep to me is very important for the patient. So if they don't sleep well, which many of them don't, they have diarrhea and abdominal pain, amitriptyline tricyclic would be a good choice. But if they have more mixed bowel habits, or you don't want them to be too constipated, then desipramine or nortriptyline would be a better choice, especially if they don't want as much sedation, because they're less sedating. But then it takes time. But that's again where you have to explain the realistic expectations and what you're trying to treat and when.
We are heading towards the end, but what about stress and the effect that it has on microbiota?
Stress actually has been shown to have an effect on the
Mhm,
microbiome.
mhm,
It can change the richness of the and the composition and the community structure of the microbiome in the
mhm.
gut. It, also, if stress increases intestinal permeability, reduces the mucus protective layer, as I mentioned before, you could have this bacterial translocation, and then you could activate the immune system more if you have that. And also, I believe there's some evidence that stress can make the enteric bacteria more pathogenic, so it can change the properties of it. But a lot of the signaling from the CNS to the gut is through catecholamine, through the sympathetic system. So there is a communication between the microbes, the metabolites they make, back to the brain, and the brain back to the gut and to the microbes. So there is definite effects of stress on the gut microbiome. But now it's not so much about the composition of the microbes that's thought to be important. It's really the metabolites that the microbes make. So that's why now studies are moving to more of metabolomic profiling, looking at the
Okay.
metabolites in the stool than really just looking at the composition of the microbes and the abundance. But there is a study that hasn't been published yet, that it was in collaboration with our group at UCLA and with Jeff Lackner, where he did that study that was published in Gastro on the efficacy of cognitive behavioral therapy in
Yep.
IBS,
Yep.
and collected stool samples before and after. And it's the baseline stool pattern that predicted response to cognitive behavioral therapy.
Okay.
I don't believe there was a change in the composition, but it was more that it predicted who was going to respond and who was not going to respond.
Yeah. Interesting. Where do you see gastroenterology, or what sort of the future hold for GI care, and from your perspective going forward, where do you think we're heading?
Probably recognizing and accepting the complexity of it and looking for phenotypic subgroups that share certain pathophysiologic mechanism that could
Mhm,
respond to a certain type of treatment
mhm.
that another group can't, even though they all meet the same symptom-based criteria. I think that's the way it's going to go. And just trying to find more, not to say to make it organic, but to really to find more biologic markers that predict treatment response, can predict just the natural course of the disease. And really, like I've been trying to do, is trying to find a diagnostic marker, which will help validate what we have and get patients diagnosed earlier into the right treatment.
Yeah.
But I think it's really just elucidating it more and probably subtyping it is what I think.
Yep. As a final question, which is what I typically ask all our guests, is there anything that we haven't spoken about that you think, or a takeaway message for potential for people that might be listening to this podcast, whether they're gastroenterologists, registrars, health professionals, or the general public?
I think for patients who have this, to know that there are scientific studies that provide a lot of validity to their symptoms.
Mm-hmm.
And just because we can't see it on a routine diagnostic test we have, it doesn't mean it's not real.
Yeah.
Because we can't really always measure physiology well in the routine studies.
Yeah.
And that there is treatment available, but it's really to have them, all of us, learn more about it and to have it more patient-centered so the patient can learn how to take care of themselves. That's what I'm really trying to get at when my
Yep.
patients, I'm trying to teach them how to manage their symptoms.
Yep.
And empower them.
Well, thank you very much, Lynn. I really, again, appreciate your time.
Thank you so much for having me, Jim.
Thank you, mate. Take care. Talk to you soon.